Today we're going to be talking about SI joint dysfunction, or maybe the lack thereof. We see a lot of patients that get sent in that have been dealing with SI joint dysfunction. I do air quotes not to mock a diagnosis or say that that's an irrelevant diagnosis, but I think it gets overdiagnosed as kind of a catch-all for a lot of different issues. When we're going to talk about the SI joint, what is SI? It's sacroiliac joint. So that is the two joints right here, below your lumbar spine, made up of the sacrum and the two iliums on either side. This is what's called a diarthrial joint. So a diarthrial joint is a very stiff joint. This joint has a decent amount of movement when we're young, but as we get older, after the second decade of life, it's going to lay down bony deposits and some plaquing to where it actually gets stiffer and stiffer and stiffer all the way until we die. So this is a highly immovable joint when we're young, and it's almost completely immovable by the time we're 70, 80 years old. So that leads me into why SI joint dysfunction is not always what we think it is. If we have a joint that is kind of like if we interlock our fingers and try to move them, that's really what your SI joint is doing when we try to take a step or we go into flexion. It locks itself. It's like the keystone in an arch. So it wedges itself down. It can take a lot of force, but it has very little movement. Most research is going to say in the multiplanar movement of the SI joint, we're only going to get 2 to 4 degrees of movement. So that's millimeters of movement. So when I get people sent in to me and they say, my SI joint is out, or I'm rotated, or it needs to be put back in, well, if it fell out, you're in a big heap of trouble because that's a lot of trauma. So that's not chronic SI joint dysfunction. Now, is that a real thing? I think it is. And what is SI joint dysfunction? In my opinion, that's where we have instability above or below the SI joint. This is a really tough joint, so what do? We recruit the toughest soldier we got in the body to put all the force on. So that SI joint starts to carry the load of a very unstable lumbar spine. We displace a lot of load. If the glute's a little maybe shut down, maybe not as active as we like it to be in a lot of our extension patterns or even flexion patterns, we're going to displace weight on what we call a passive closure of that SI joint instead of a forced closure where we actually use the glute to shut that SI joint down to move through extension very cleanly. So these will be the people that you see that live in a lot of lumbar extension and they're literally riding on their SI joints. Can you get referred pain from the SI joint? Absolutely. We can get sclerotogenous pain, which is kind of the pain where people just say, it's all over here, doc. Something like that. You can also get sciatic type symptoms because we have a lot of soft tissue structures that cross over the SI joint, mostly ligaments, very strong ligaments, because again, this takes a lot of force, but it's not a lot of movement. This thing needs to be able to lock down, so when we go to take off and sprint or single leg jump or bound, that this thing can lock down and we can move through hip extension very powerfully with all these big glutes. So, what do we do if we have SI joint dysfunction? We're not here to diagnose anybody via video, we're not here to treat anybody via video. But a good idea would be to take into mind Gray Cook's alternating pattern of mobile stable joints in the body. The lumbar spine is supposed to be stable and our lumbopelvic, or mainly our hips, are supposed to be mobile. Maybe we want to get back to that scenario because we're probably too tight here and too mobile here, displacing a lot of force on the SI joints. So go check us out on chirofarm.com. Check out the hip thigh video section and the core section. There may be some things that help you. If not, get a hold of us.